Professor Rosano, and he will discuss with us whether it's time to reconsider our beliefs toward PCI.
I promise it's last time you see me today on the podium. So this is my declaration of interest. And I will try to give a different approach to the interplay between medical therapy and PCI. Now, we know, first of all, what is important in terms of future events in patients with ischemic heart disease is not the presence or not of ischemia, but is the presence of angina. You see that patients with angina have a significantly higher incidence of myocardial infarction, death and myocardial infarction, or need of revascularization. That is not the case when only ischemia is assessed. Of course, when angina and ischemia coexist, then there's a greater risk of future events. So what that means is that we, rather than targeting ischemia, we need to target and treat more intensively our patients with angina. Now, we also know that the frequency of angina is associated with an effect on quality of life, but also in terms of cost and expenditure. And you can see that those patients with daily episodes of angina have a significantly increased cost for our healthcare. Another important point is how angina and patients with coronary artery disease then behave on the long term. You see that in the significant proportion of patients are readmitted because of unstable angina. The 4% is admitted for PCI and 5% for congestive heart failure. So in terms of assessing long-term events, the importance of rehospitalizations for angina is important because it's a very important component of what we use as MACE, which is death, myocardial infarction, strokes, and rehospitalization. So rehospitalizations are important, and we need to keep that in mind. And we should do as we do in heart failure, where heart failure hospitalizations are an endpoint that is very important. And I borrowed this slide from Professor Ferrari, this and the next one, I believe. And that is put that in a very, very nice book that I think I urge to suggest. I mean, it's as a special place in my library, and with beautiful imaging of coronary circulation. And basically, it shows you the view of the coronary syndromes. And that is also the approach that some of our colleagues who always are in the cath lab tend to look at coronary artery disease. So like a clogged pipe, and therefore you need to open up what is clogged. But the problem is sometimes we end up with this. I mean, this is a paper was published in the Journal American College of Cardiology several years ago. You can see this gentleman had received 67 stents in between all these three vessels. And so that is what sometimes ends up. And the issue is that often we don't think at patients, because if anything happens on this LAD, there's no space for the surgeon to put a mammary. There's no space to have a complete revascularization, surgical revascularization. So that is something we have to put into context when we assess the indication for intervention, and special intervention that require the implantation of stents. Now, we know also a very important point, and that came from the ischemia trial, that the ischemia trial was a study where the patients were believed to have a very significant ischemia, and based on non-invasive testing and symptoms, they underwent a CTCA. And the reason of conducting a CTCA was to exclude the presence of left main disease, and that in order to allow patients to be randomized to medical therapy or to intervention. But what was interesting is that 21% of patients who were believed to have a true angina that had positive provocative tests had normal coronary arteries. So there's a sizable proportion, and that proportion of patients with normal coronary arteries in the past 30, 40 years has always averaged around 20 to 30%. If you look back at the CAS study, the coronary artery surgery study, it was published in the mid-80s, it was 30% then. So it's now, the range is between 20 and 30%. So patients with angina often have normal coronary arteries. And this is, again, from, I think, from Professor Ferrari's book. And you can see the importance of the microcirculation, where basically the red blood cells, they have to squeeze into the coronary artery. And that tells you the importance of microcirculation, because if you have a vasoconstriction, then or less vasodilation, then there is an effect on clogging. And it's basically what you see when you do an angiography and you see this slow runoff of contrast. Then, therefore, our understanding of ischemic heart disease has changed. Now we know that for the acute coronary syndromes, we have STEMI and STEMI, but also we have patients with myocardial infarction with normal coronary arteries. And the same is true for patients with stable coronary syndromes, where we have patients with obstructive disease, but we have also a significant proportion of patients with normal coronary arteries. And in those patients, and I think this is a very important paper because it's basically confirms what Ambrose published in the 1985 and 1987, where he looked at the occurrence of myocardial infarctions in patients with different degrees of stenosis. And at that time, they showed that patients with stenosis less than 60% were those who were more likely to have a myocardial infarction. So it's not the size of the stenosis, but it's more the probability of that stenosis to become unstable and induce a myocardial event. In this study, you can see the size of the obstruction, but also related to the presence of instability of plaque morphology. And you can see that those patients with a thin cap of plaque, those at any degree of stenosis are those who tend more to induce to rupture and to induce an acute coronary event. So it doesn't matter whether you have more than 70% or 30% of stenosis. What matters is whether the thin cap is present or not, and whether that plaque is going to rupture. And this is basically a segue, and that is in keeping with what we see in long-term clinical trials with interventions. I mean, we used to, in the past, to give an indication to treat patients with a stenosis greater than 70%. Now we've heard about the FFR, but the FFR is basically based on registry studies and not prospective studies. And so we may want to discuss on the importance of FFR per se. But if we look at all clinical trials that have been conducted so far, then there's never been evidence of a clear superiority of PCI of a medical therapy in terms of future cardiovascular events. And if we look at the recent Orbiter study that was conducted in the UK, where patients were randomized to receive a PCI or not, and but they were put asleep and they had a femoral puncture anyway. So you can see that patients had a certain benefit on angina, so there is a clear evidence on angina, but that was limited only to few subgroup of patients. So there's no doubt that the intervention is effective in improving symptoms. Whether that has an effect on prognosis is still a matter of discussion. These are the data from the ischemia study. You see that there was, at the end of the study, there was no difference between conservative or invasive treatment. And you may say that you have a benefit after 4 years, or there's a tendency to get a benefit over 2 years, but you pay the price at the beginning with an increased risk of events. So overall, there was no benefit on the primary outcome of intervention of medical therapy. I think that will put an end of the story that started with the Baritar trial, then went through the Courage, and now with ischemia, on the difference between the intervention and medical therapy. And we can see that even if we look at hard endpoints like all-cause death, the two curves of medical therapy and intervention were superimposable. Now, and also when you look at recurrent events, so when you look at more than one hospitalization, you see that the risk of events is similar between intervention and medical therapy in the trial. So what is the treatment approach? And I think on that, all the guidelines for patients with angina, I think in that the guidelines are pretty much concordant. I mean, the ESC and the American guidelines, and they say that the initial management of patients with angina is medical therapy. Point is that they are similar, and in terms of prognosis, there's no benefit of one or the other. And that is, and then we have to individualize our medical therapy. Now, regarding medical therapy, I think that there's a major problem that comes from the guidelines, and that is mostly on the way guidelines indicate first line and second line medical therapy. And if you read through the ESC guidelines, they say that there's a preferred use of beta blockers because of their readily available and cheap. But if you look at the effect of beta blockers in patients with left ventricular function greater than 40%, there's no trials, no registries have, and this is just one of the many data on beta blockers that have ever shown that beta blockers improve survival in patients with ischemic heart disease. So in ischemic heart disease, there's clearly no single trial that has ever shown a benefit for beta blockers. Then we use the long-term nitrates with understanding that they work, but we transfer often what is written in the guidelines to chronic nitrates, because the guidelines give an indication for short-acting nitrates compared to the long-term nitrates are used widely in patients with ischemic heart disease, while we know that over time they have no effect on exercise duration and on anti-ischemic effects. Then again, I borrowed this from Professor Ferrari, who came with this brilliant idea a few years ago of looking at patients on as a whole and looking at patients with comorbidities. And I have to say that we also use that in heart failure, where we suggested a patient phenotyping. And basically, in this paper, he identified all the different possible causes of myocardial ischemia, and also separately also comorbidities. And you can see that patients may have microvascular dysfunction, they may have coronary vasospasm, they may have a fixed stenosis, and there are different indications of different treatments according to the different conditions. Because if you get a patient with vasospastic angina, there's clear no role for the beta blockers that may even increase vasospasm. And whilst for patients with left ventricular dysfunction, then there's a clear indication for drugs like beta blockers and ivabradine. And another important point is something we always forget, is the fact that if you use two hemodynamic agents together, they don't have any additive effect. So if you add a beta blocker to a nitrate to a beta blocker, or a calcium channel blocker to a beta blocker, there are three large randomized trials that have shown that the hemodynamic agents do not add any anti-ischemic effect. While if you use different approaches, you may get a beneficial effect. And these are data from the associate study, where they looked at the heart rate reduction with beta blockers and ivabradine, and they clearly shown that the association of two different approaches in reducing heart rate has additive effect, as beta blockers and ivabradine are more effective. And this is, I think, is the best proof to show you that different agents with different mechanism of action have effect, whilst two hemodynamic agents do not work together. In this study, they took patients on beta blockers and they randomized them to receive either dinitrate or trimetazidine, that it works as a metabolic agent. So if you look at the effect of the nitrates, you see there was no effect of nitrates on the ischemic threshold on time to angina. So thereby confirming the fact that there's no additive effect of two anti-anginal medications, whilst when they added the trametazidine, there was a significant increase in ischemic threshold and time to angina. And these are the data that have been analyzed by the Italian Institute of Health, and this is the first author is Cristiana Vitale, who's here. And there was on the Vasco study, there's the largest ever conducted study in angina where patients receiving atenolol were randomized to receive trametazidine or placebo. You can see there was a significant improvement in exercise threshold and ischemia with trametazidine. And what was interesting from that study, and I think that is something that a company doesn't want to often to communicate, is the fact that we don't have a clear idea what is the top dose of the medications we can use, as the 140 milligrams was even more, it was more effective than the standard 70 milligrams. So 70 milligrams twice daily is even more effective. But the 70 milligrams, so the 35 milligrams twice daily, are very effective in improving symptoms. We have to understand that with metabolic therapies, we don't have the same immediate effect that we see with the hemodynamic agents. And this is true for all the metabolic agents, all the metabolic interventions. You see, these are the data with trametazidine in patients who are taking all different sorts of combinations of hemodynamic agents. These were patients on beta blockers and calcium channel blockers, long-acting nitrates, combination of the three. You see, it takes a few months to get the best of the effect. And about after 6 months, there's a very significant reduction in events. And that is true in patients with silent or symptomatic ischemias. We did demonstrate many years ago where we showed that even patients that we thought were completely asymptomatic receiving metabolic therapy with trametazidine had a significant reduction in the number of episodes for silent ischemia and total duration of ischemia. Then this was a study that we conducted just to demonstrate that you can switch patients who are on nitrates to get a greater effect, especially if they have to take a PDE5 inhibitor. So we took patients and we put a 24-hour ECG monitoring and asked them to have a sexual intercourse during the monitoring and randomized them to have either trametazidine or nitrates, and then we gave sildenafil to these patients. And you can see that there was a significant reduction of the episodes of myocardial ischemia. So despite having cheap drugs that we don't, they are not often acknowledged too much, then we see that and we thought back in the early 2000 that the metabolic approach could also have an effect on left ventricular function. And therefore, we pioneered the studies on in patients with heart failure using a metabolic approach with trametazidine in this case, and many other studies followed. And I always like to show not one single study, but then meta-analysis. Because if you look at the meta-analysis and the results are always on the same side, it means that the effect is very consistent. And you can see that in patients with or without ischemic origin, there's a benefit of in patients with left ventricular dysfunction on exercise capacity, on left ventricular function, and also on mortality. This is my last slide, and to say that our approach to patients with ischemic heart disease depends on the entry point, and that medical therapy and revascularization shouldn't be seen as either or, but should be seen in the normal life of patients with ischemic heart disease. You may have a patient that comes in an acute coronary syndrome and gets an immediate revascularization. PCI is life-saving in the acute coronary settings. And but then that patient will have to take medical therapy, and that will be for life, and they may require further revascularization for the quality of life. Then you may have other patients who come in and they receive medical therapy. They will be very well for most of their life with medical therapy, but at some point, they may get worsened. They may, because of progression of disease, they get more symptomatic, and then then revascularization should be an option to reconsider keeping them always on medical therapy. So we have to look at the use of interventions with fresh eyes and say, consider the patient in itself, or and then consider whether medical therapy or revascularization should be considered. Of course, I'm talking only about PCI. I'm not talking about coronary revascularization that is effective and safe and improves survival. But what is important is not to see them as alternative, but they work together. And even patients who receive a revascularization should be on optimal medical therapy. Thank you very much for your attention.